Welcome to our 9th webinar and the first in a 4-part clinical education series. So our webinars follow different themes, and for the next 4, we'll be talking about kind of implementation and practical aspects of delivering palliative care and clinical education. And we're absolutely delighted to have Dr. Kathryn Richardson and Dr. Megan Doherty, both very experienced. Kathryn is with us live, which is great. And Megan, we're using the recording from yesterday's webinar. And that'll be too helpful, excellent. They were very specific and helping us think through the details of how we would develop palliative care. We'll then have discussion. And today we have 3 panelists. We have Savita Botola from the BSF in India. We have Matteo Serra, who worked with MSF in Guatemala. And we have Mark Moisaji, who's who leads the Palliative Care Association in Uganda. But we'll introduce properly after we've heard the first couple of talks. I'm Moira Leng, palliative care global physician based in Uganda a lot of the time, but also in Gaza, India, Mauritania, Sudan. And it's lovely to be with you this morning. We have other members of our exec on the call, and we'll have plenty of time, I hope, to discuss after our 2 presentations. As we did yesterday, we just stopped for a moment at the beginning and just thought of areas in the world where our members in this network are facing particular challenge. And I'll just mention some of them. If I forget some, forgive me, but just to remember colleagues, particularly in Sudan today, where things are very, very difficult, and they've been contacting us and are safe at the moment. But we also remember colleagues in the aftermath of the earthquakes in Turkey and Syria. We remember colleagues in Malawi and Mozambique with the recent floods. We continue to remember colleagues in Ukraine, in Myanmar, and actually also just to hold these places for all of those they're caring for. And that's the reason why we're here today, is because we do care about what's happening in these situations and how we can respond in terms of palliative care. So we'll just take a moment of silence. Thank you. And we see a few more members have told us where they're from. Welcome from Homa Bay in Kenya. Lovely to have you. And welcome also Marianne from Western Australia. So we're going to hand over, first of all, to Kathryn. Kathryn will introduce herself, I think, but she's a palliative care physician working with MSF. Kathryn, we're looking forward to your talk this morning.
Super. Okay, so my name's Kathryn. I'm a palliative care specialist, as Moira said, based in Geneva at the moment, and I've been working with MSF over the last 4 years. And today's webinar will be focusing on the programmatic elements of implementing palliative care in humanitarian settings. And this session in particular will focus on who needs palliative care in humanitarian medical response, but also what are the steps for implementing palliative care. So when we think about who needs palliative care in humanitarian response, it won't surprise you to learn that it's actually the same patients that need palliative care in any other setting. So it's any patient that has severe health-related suffering due to a severe illness, or any patient that's living with a life-limiting condition or suffering from a life-threatening condition. And of course, we need to think about supporting the family too. And many of you will know that when we look at the global needs for palliative care and the most common diseases requiring palliative care, amongst adults, the most prevalent conditions are cancer, HIV, and cerebrovascular disease. And amongst children, the most prevalent conditions are HIV, extreme prematurity, birth trauma, and severe congenital malformations. And this may be severe that would be fatal in another setting, or they may be severe that do not have access to surgical correction, so therefore require palliative care in low resource setting. When we think about humanitarian crisis, there's a few other considerations and increased need actually for palliative care. And that's epidemics with life-threatening infections, conflicts or disasters are all associated with higher mortality, and so higher need for palliative care. When we think about displaced populations, so this is either people who are internally displaced within a country or as refugees, so over the border into another country, Many of these people will have had their medical care interrupted. So there would be conditions that would normally be under treatment that will not have access to treatment anymore. So an increased need for palliative care. And it's worth recognizing as well that many refugees actually come from unstable, unsafe countries where they may not have had access to care for their chronic conditions anyway. So higher needs for palliative care in humanitarian settings. And I'm sharing with you here some of the groups of patients that we've recognized have, really this is from projects that have called out for support with palliative care. And we found that those that really need palliative care are projects focusing on newborns, neonates in humanitarian settings that have very low chance of survival. So a lot of extreme prematurity, severe congenital abnormalities, and no access to corrective surgery. We see quite a lot of children with congenital cardiac disease who do not have access to specialist cardiac surgery, and children and adults living with particular conditions. So in particular, advanced HIV, we found a lot of needs for palliative care, MDR, TB, other life-threatening infections, of course, and also NCDs. Okay? And it's also worth reflecting in low resource settings, often in humanitarian context, often whereas an acute renal failure may be able to have supportive treatment to improve in some settings, in humanitarian settings there's more secondary level, more advanced care often isn't available. So they become, they're usually terminal conditions. And of course, patients that are suffering from trauma and extensive burns all may need palliative care too. And I think it's worth also remembering that, we say humanitarian context, and what do we mean by that? And, in different countries, what is available will be different, okay? And that will be in part due to the countries. So what will be available in an urban centre in India will be very different from what's available, let's say, and we've got some colleagues from South Sudan today, from a rural setting in South Sudan. So what the capacities are, an MRI scan may be possible for an advanced HIV patient in one setting, and it certainly wouldn't be possible in another setting. So I think we need to remember that how we can diagnose and how we can treat is very much dependent on resources available and also referral options. Okay, so is there anywhere to refer for a higher level of care? Another thing that impacts actually on palliative care need is access to medicines and medical supply. And in many humanitarian contexts, there is not always a secure and stable supply of medicines such as ARVs and TB medications in the long term. And this can be problematic for many of our patients and increase palliative care needs. So I want to share some of my learning for the steps that are needed to implement palliative care in humanitarian settings. And I know many of you on the call have experience as well and expertise from your own practice. And it'll be really interesting to hear from you in the discussion about any learning that you have on implementing palliative care. So I've tried to put this into 3 blocks. So the planning phase, the implementation phase, and the monitoring and data collection. And when we think about planning, we need to think about where we're going to start. So what are the most urgent needs that we recognize in a setting? And it might be that you have a lot of unmanaged pain, and so you want to focus on pain management. I know certainly in South Sudan, when we implemented in Bentiu, what the team were facing was a lot of high mortality in the adult inpatient unit. So the focus was really on improving the care of dying patients in the inpatient setting. We also need to think about which patients. So is it amongst the newborns that we have high mortality? Is it amongst pediatric patients, for example, in the inpatient therapeutic feeding center, there's high mortality? Is it on the adult ward? Is it in the community? So we need to think about which groups and where are the highest needs. And is it linked to a disease? And sometimes we have projects that will be focused on a particular condition, such as advanced HIV or TB, or we may have a project that's heavily focused on malnutrition. And so it may be a disease-specific focus when we're thinking about implementing palliative care. And we also think about the setting. So are we thinking about implementing in an inpatient setting? Are we going to introduce it into our outpatient clinics? Or are we going to set up a home care service so we can reach patients who are not able to reach us? And so these are just some of the things to think about. And what we found is that it's often better to start in one setting with one, whether it's adults or whether it's neonates, and get the teams, the skills, the confidence, and then slowly try to expand the service out. And deciding where to start will also be influenced by which resources we have available, okay, and also the context in which you're working. So do we have staff who are already providing generalized medical care who can be trained to provide palliative care, or are we starting a new service and we need to recruit staff? Do we have a facility? Do we have a supply of medicines? Is it safe to do home visits in this context? Okay, and one issue we had certainly in India, we're setting up some home palliative care in India. One issue was the distance actually to travel. So we had, for some patients, a 6-hour journey to reach their home in Bihar province. And so how can you manage that when you're doing a home care service? Do you need to have some phone consultations? Do we have satellite teams? Also, is it safe? So in some settings, if we're working in conflict zones, it may not be actually safe to do home visits. So all of these considerations will help inform where to start and what sort of service you can provide. And whenever setting up a palliative care service, it's important to find out what's going on already in the country that you're working in. So is there a national palliative care association? Are there any ongoing palliative care services within the country? So you can see what kind of model of palliative care is in use, and how is it being done? How has it been adapted to this culture, to this context? And also think about which other actors are providing care for the community you want to serve. So are there already possibilities for palliative care, whether it's inpatients or home care service within this population? What can we add in to complement, or what is already being provided? And think about what other resources might be available. So you may have some community activists or social action groups who are keen to get involved and support. There may be other actors that are already providing services that can complement the care that you want to provide, whether that's mental health, whether that's support with equipment or other resources. And it's important to engage with the community from an early stage. Okay, so it's important to engage with the community, and this also means the staff that will be providing care. And it's important to do this for several reasons. One is to understand what people think about palliative care, and what often there's misunderstandings and misconceptions. And this is common in many settings, and we know that talking about death is often taboo in many cultures. So it's important to understand, what do people think palliative care is, and try to unpick any myths, certainly within the staff, about what palliative care is. And often it gets confused with euthanasia and assisted suicide, of course. So all those things need to be unpicked. And death and dying are very deeply rooted within cultural norms and values. And so we need to make sure that the palliative care being provided is appropriate and adapted for the context. And we also need to make sure that people are engaged with the planning phase, because actually a lot of the families are going to be the ones that are providing care at home. The communities are going to be involved in care, and so they need to also be involved in saying and sharing what is needed in their view. And we like, wherever possible, to do what I call sort of an assessment, so some sort of collect some qualitative data before implementing. And this is to understand more about the values, practices, and beliefs around death and dying within a community. And this mustn't become a barrier to implementing palliative care. So it doesn't need to be an expensive piece of research, but it should be something that's simple, that's can be done quite quickly, and just as a guide to how you're going to move forward when implementing the service. And this can be done with focus group discussions. You might use some key informant interviews, for example, with religious leaders and staff members. And you need to just explore more about, what do people think about these conditions for which you want to provide palliative care? What's the understanding about the origins of them? What are the priorities of the community in terms of their health? And what has been their experience so far when they try and access care for these conditions? And it's also important to ask, what do the community feel they need and what is missing for when people have a serious illness and when they're facing end of life. And it's important to understand more about, let's say, communication norms when it comes to healthcare, as well as who would normally have decision-making capacity. And an example, I worked in Jordan for several years, and there it was very normal. It was very normal that a doctor would speak to the family about the condition and never the patient. And so you need to know that. You absolutely need to know what the normal communication network is. And then, of course, each patient is individual, but we need to know what would be, what a family would expect, what a person might expect in this culture in terms of how communication happens. And it's important to find out more about burial practices and rituals around the time of death, and also place of death. So certainly when we were working in India, it was 98% of patients, when we asked, wanted to die at home. So if you're thinking about which service you're setting up, if the population's norm and expectation was they wanted end-of-life care in the home, then that may shift how you design your service. So you need to have some home care support there for supporting them. And assessment ideally is ongoing. So you would go on and engage with the community at various times during after implementation of the service. And it's important to say if there's some big changes within the population, for example, a big influx of new refugees or new outbreaks of disease, it's important to go back and start asking about what people's understanding is about the disease, the new outbreak, etc. So thinking about implementation, I'm not going to say much about each of these areas, but it's important to develop some minimum standards for practice. So you know what you want to implement, what would be the minimum standard for palliative care in this setting. It's important to have, think about your resources. So funding, do you have the budget to continue the service? Do you have the right staff and the multidisciplinary team as far as possible? You need to think about your health facility, any transportation, certainly for home care, and also supplies of essential medicines and equipment. And I've just put a couple of, so the WHO and International Association of Hospice and Palliative Care both have essential medicines and equipment lists that you can refer to. And also think about training. So you need an initial, more intensive training for your staff, but then you do need to continue ongoing support and training. So it's not a one-time event, but you do need an initial, more intensive training program. You need to think through how you're going to support that. And just to mention something about access to opioids, and of course, if you want to manage pain and breathlessness for patients with advanced disease, then often we do need access to oral morphine. And this is a particular because it is a controlled drug. And so there are often many barriers to gaining access for it for our patients in humanitarian contexts. And the barriers are often more than one. And in many countries, there are regulatory restrictions which go beyond actually what the international law requires. Okay, so that's one hurdle. Another is around knowledge, and often I find that the doctors, the clinical officers working in humanitarian context have no experience of using opioids. They've never been able to access them, so they need both the knowledge, but also they need to see how they can work. And I know in South Sudan, and perhaps our colleagues on the call can share later, that excuse me, that when we started using palliative care for pain and breathlessness in small doses, there was real excitement that actually they had a huge impact on patients. And just seeing that impact can really give the doctors the confidence to continue using them and for the benefits of improving the symptoms. And when we, another barrier is often lack of awareness. So often if patients have never known pain control exists or there's access to it, they may not come asking for it. And also access to care. So we know a lot of the patients that need palliative care may have reduced mobility, they may not present to health services, and of course some conditions have a stigma too, which may present them accessing care. So when you're thinking about, through, make sure you understand what are the local regulations and import rules. Be aware there are some special procedures that can be used for emergency situations. So when there are no authorities to grant imports access, or after a disaster, there are some special circumstances where you can bypass the usual procedure. And also be aware if there's anything particular in the country in terms of how you need to storage and reporting. So I know in some settings you need to keep all the empty boxes and vials for oral morphine and return them all to a central authority. So just be aware of what the rules are where you work. And just a short mention, I'm just going to check the time. Yeah, I probably need to start wrapping up. A short mention on staff. So often it's going to be generalist healthcare staff providing palliative care. So just this is going to be the level, but we need to think about what support we can provide for those staff. So this might be through telemedicine, that's what the model we use in MSF. It might be through a regular case discussion where we can share, go through cases together and discuss, appropriate management and have learning through that way. But then there does need to be a specialist palliative care support somehow. And we found it helpful to have leads and focal points for palliative care within each project. So just very briefly on monitoring, so it's important to have minimum data collection and ideally some indicators as well as some regular opportunities for feedback from patients, caregivers and staff. And here is some of the data collection that the minimum data collection that I would suggest, and we'll share the slide, so I'm not going to go through that now for the interest of time. And some indicators, and really the indicators are clearly defined ways to sort of show the impact of your service. And it's helpful to secure funding to show the impact of your service and get resources to continue. And it's also helpful for service improvement as well. And the data you collect will input into these indicators so that you have this regular monitoring of the service being provided. And that's it. That's all I'll say. Thank you very much, and I'll hand back to you, Moira.
Thank you so much, Kathryn, and thank you for all the kind of practical experience there. And I know that MSF have been doing a lot of work on developing a toolkit, and thank you for that. And it's great to have colleagues, particularly from South Sudan and who's worked in Guatemala, that can talk a bit more about the MSF perspective, but also that wider humanitarian perspective. Welcome to the members who've joined us, and I can see colleagues joining from, great to have Mark with us, Mark Messity, who's one of our panelists from Uganda, and I can see other colleagues joining. Please do tell us in the chat where you're joining from and something about your setting. That would be great. We'll move straight on to the next, which is a video. Can I ask you to turn up your volumes? We found this video, the sound's a little bit low, so if you can turn up your volumes, please do that. And we'll listen to that. And I think we'll go straight to that because our time's a bit tight.
Hello, and welcome to this presentation that will describe experiences in assessing palliative care needs and barriers in humanitarian settings. My objectives for today are to help you understand the specific palliative care needs in humanitarian contexts, and to describe how to conduct a palliative care needs assessment in a humanitarian setting, describing key lessons learned from our previous experiences doing this. I'm going to use the example of the Rohingya refugee crisis in Cox's Bazar, Bangladesh, to illustrate these points. This refugee crisis began in 2017 when almost 900,000 refugees arrived from Myanmar. They were fleeing violence, and they arrived in a remote area on the border in Bangladesh. And more than 60% of these refugees were children. So at this time, at the end of 2017, we had a big challenge in this community, is that we didn't know about the individuals with serious illnesses and what were their palliative care needs. So we decided to conduct a rapid situational analysis of the Rohingya refugee situation. And our goal was to describe the needs of children and adults living with serious or life-threatening illnesses. We wanted to understand the specific challenges they faced in accessing medical care and their basic needs, and understand how the available health resources, including pharmaceutical and health facilities, were able to support them or not. I'm going to just discuss some key points and lessons that we learned from our experience. The first was the importance of really going and listening to the patients and caregivers themselves. So in our needs assessment, we conducted interviews. We went house to house, identifying individuals with palliative care needs and their caregivers, and interviewing them about their needs. We used convenience sampling methodology, and the sample size was determined by the maximum number of eligible participants that could be consented and interviewed during the data collection period. These are some key techniques that you can use or consider using if you were to do a similar needs assessment in another humanitarian crisis. There were additional components to our study, and I will discuss them in the coming slides. And this figure just shows one of our interviewers, a young Rohingya man, interviewing a patient in their own home about their palliative care needs. Another key lesson that we identified was how important the interviewers were. We had to train and support our interviewers. They were young people from the Rohingya camps themselves. They spoke Rohingya and they had grown up living in the refugee camp. The vast majority of them had actually come to Bangladesh as children or had been born in the refugee camps because there had been previous waves of migration of Rohingya from Myanmar into Bangladesh. So they had not just arrived, they had arrived many years before or actually had lived their whole life in the camps. But the advantage was they knew the camp situation well and they spoke the same language as those who had newly arrived. You can see on the right-hand side an image of Dr. Farzana Khan, my colleague and palliative care physician in Bangladesh, who is training these interviewers. We provided 2 days training, and this included a substantial portion of role-playing with them practicing conducting the interviews because they had to ask questions about what type of serious illness the individual had and their pain and other symptoms, which would be challenging for people without any background in healthcare to ask. So we spent a lot of time reviewing the exact wording that they would use in Rohingya to ask these questions and the responses that they might receive and how they would write those down. We also provided field supervision of the surveyors. So we went with them and sat in on the interviews in the patients' homes, listening and supporting them to conduct the interviews. And we did this in partnership with an organization called OBAD Helpers. And I want to highlight this partnership because it was key. This is an NGO in Bangladesh which has existing activities in Bangladesh in the field of health. And we were able to partner with them to use their facilities, including this house that I show you in the top right-hand corner, where we could train our surveyors and we could have sort of a base from which our surveyors went out every day to do the interviews. And also they actually helped us find the individuals who interviewed for us. They were workers who had been working with OBAD Helpers previously. And this is particularly important in a humanitarian crisis situation when often the crisis can arise suddenly and a whole bunch of aid organizations will flood into the area where the refugees are, and this can mean there are very few resources available. We weren't able to find, another facility to rent to do the training. It was very hard to find and rent vehicles because they were all the local rental vehicles had been used up and rented up by other humanitarian aid organizations. Another key consideration when you're considering doing a needs assessment is who to interview. You want to identify palliative care, individuals needing palliative care, but how do you identify them? They don't just walk around saying, I need palliative care. So you want to train your interviewers to be able to identify individuals with serious illness. Again, this requires training and discussion and providing them with examples. We also provided them with the option to check in by phone with one of the study coordinators who was a physician to make sure that that the patient was appropriate for an interview. We wanted to include children, and I emphasize this point because many times when this kind of work is done, the thought is, children are more vulnerable, it's difficult to assess them or identify them, so they get overlooked. But we felt it was very important to include children, and we just interviewed a parent or primary caregiver adult. And then the other question to ask is, what about the host population? So 900,000 Rohingya refugees had moved into an area with a local host population of several hundred thousand, and that host population also likely had significant palliative care needs because there weren't actually existing palliative care services in that region. So you may want to consider how you would assess the palliative care needs for the host population at the same time so that you don't create disparities in the health systems between what's available for the refugees and what's available for the locals. We also found it very important to spend some time properly developing an interview guide or your survey tools or questionnaires. And we did this all very rapidly, even though there were a number of steps. We conducted this all within 2 weeks time frame. We started with a literature review where we looked at the SPHERE guidelines, which are standards for healthcare delivery in humanitarian settings, and they had included palliative care for the first time. So we took that plus additional literature, including specifically, we looked at previous palliative care needs assessments that had been done in low and middle income settings, and a needs assessment had been done nationally in Bangladesh the year before we did this needs assessment, so that was very helpful. All of this was put together into a draft interview guide, which then we received input and feedback from a global group of content experts, including palliative care physicians, nurses, experts in non-communicable diseases, and experts in humanitarian healthcare. This led to the development of a pilot interview guide, which we tested with 10 Rohingya interviewers, and then we had them pilot test it with 20 Rohingya patients and caregivers. And there were substantial modifications in this phase to improve the clarity of the questions and the response options based on what would be appropriate for the Rohingya culture and the refugees' experiences. And finally, this led to 2 final interview guides, one for patients and one for caregivers. The type of data that we ended up collecting from these interviews included the type of serious medical condition and treatment that the patient was receiving, and could they access those treatments. The presence of pain and other symptoms, including treatments for symptoms and pain and their efficacy. The individual's need for medicines and other medical supplies. Their basic needs, such as food and shelter, and were these adequately met. Their healthcare seeking behaviors. Had they recently had any healthcare experiences, and what were the barriers they experienced to accessing healthcare and treatment? And for caregivers, we focused primarily on their caregiving responsibilities, training that they had or needed to be able to care for the individual who was seriously ill, and their support needs. I'll highlight a few key findings from our needs assessment. One was about pain and pain relief. We didn't find any patients who received opioids. There were no retail pharmacies that stocked opioids that we could identify. And there was only one health facility in the whole region that had opioids in stock. Many patients with pain received paracetamol or non-steroidal anti-inflammatories, but they reported that most of the time, these medicines did not give them any pain relief. When we looked at patients accessing healthcare itself, they frequently visited health facilities. In fact, most had visited a health facility in the past few weeks. But they said that 60% of the time, these encounters didn't actually address their concerns and didn't fix their problem. And they reported some common barriers to accessing healthcare, including money, the fact that treatment for their specific condition was not actually available from health centers, and the need for transportation. And transportation was particularly important because the camps are in a very rural area and were built on very rugged terrain, very hilly, and very difficult to navigate on foot if you aren't able-bodied. We also looked at patients' basic and essential needs, and when we asked the question, what is your greatest need? They said medication. In fact, 97% of them said that, and most had stopped taking medications because of the cost. Money was their second greatest need. Food, pain relief, and someone to care for them were also very substantial needs. Caregivers' needs included the fact that it was very physically demanding to care for the sick individual. They didn't have any help. Caring for the individual caused them sadness or anxiety, and they reported a lack of time and money. There were 2 additional components to our needs assessment, which I won't go over in detail, but I want to highlight that it's important to conduct these parts as well. First off, we looked at health facilities. So we went to all the key health facilities in the region, and we looked at their opioid availability and what was their provisions for care for patients with serious illnesses. You can see several images on the left of the Red Cross Field Hospital, which was actually relatively well equipped and did have opioids available. It included even a playroom, as you can see in the top right. But this hospital would stay in place for only the first 6 months of the crisis. And 5 years on, the patients and Rohingya refugees are still in Bangladesh. The second other part of our needs assessment was a pharmacy survey. So we surveyed all the retail pharmacies in the region that we could identify. And in fact, there were very few because, like I said, it was a very, very rural area. And actually, a lot of it was jungle before the refugee camps were set up there. But at the local pharmacies, we were looking for which medicines they had available from the WHO Essential Medicine Package for palliative care. And you can see an image of one of the pharmacists that we interviewed in the middle of this slide. And then on the right-hand side, you can see an image of myself and Dr. Farzana meeting with the team from Handicap International, so another health provider in the Rohingya camps. And so we made sure to visit not only health facilities, but also health providers who were caring for some individuals who may have palliative care needs. And so it was actually very useful for us to meet with these organizations because later on, as we started to develop a palliative care program in the Rohingya camps, we were able to collaborate and leverage the services that other organizations provided. The last component of a needs assessment is knowledge dissemination. And some key learnings that we had from this stage was that you need to have the access to the right people. So we had to make contacts within the World Health Organization and the International Organization for Migration. And once we had preliminary data, it was very helpful that we were able to share that very quickly with them. We were able to meet with them. We went to the NCD group meetings, and we were able to highlight these significant gaps in the provision of palliative care and care for individuals with serious illnesses. We chose to focus on writing and disseminating an advocacy report first, which was called Neglected Suffering, the Unmet Need for Palliative Care in Cox's Bazar. And this came out in March 2018, so very within 3 months of our needs assessment. And as you can see, our academic article, which is shown on the right, took 2 more years to get published. So that's why we really focused on the advocacy report first, because we knew we could get that out quickly and that this would make a difference. It was in less scientific or academic language and was very readily accessible. And we used this to promote palliative care and really speak about the need for palliative care. Lastly, I want to discuss how this needs implementation led directly to a community-based program, which we used everything we learned from the needs assessment in itself, and we took it and we put it into a plan to implement palliative care. Almost immediately after the needs assessment was done, we were able to start implementing palliative care because we really understood the needs of the patients and the families. And we knew from our health facilities and our pharmacy surveys that there wasn't palliative care available and there weren't the medications available. So we used our knowledge of how the palliative care system and opioid availability worked in Bangladesh, and we were able to bring some of that right into the Rohingya camps. Other things we did from our needs assessment was to leverage our implementation is to use some of our interviewers to then become community health workers if they wanted to be. So you'll see these 2 individuals in the image on the left. First, they did the interviews, and then they became trained to become community health workers in the Rohingya camps. And some of the individuals who were part of the needs assessment were also taken up into the palliative care program if they were in the region where we started our first pilot palliative care program. And there's a couple really excellent links here on the right that show you more about the program that was implemented by the IOM, which was based on our initial needs assessment work.
Thanks, Erin. And sorry for those of you who were having a challenge with your volume there. We'll try and see if we can do something about that in future webinars. But we've had 2 great talks, one focusing from Kathryn about how you identify and what you do, and really practical about how you implement palliative care, and then the experience of the needs assessment, which is such an important component. Now we have time for discussion and interaction, and again, a welcome to those who've joined us. And thank you for many of you for putting your contacts and your names in the chat. And I see we've got colleagues joining us from Iran, from different parts of Africa, from Kenya, from, I think, South Africa, from KwaZulu-Natal, and also Gadir, welcome from King Hussein Cancer Center, and from Ghana. So lovely to have you all join us. You're all very important, Malawi as well. So I want to introduce now our panelists. So we have Matteo. Matteo is a nurse from Spain, but is particularly going to be talking about or linking his comments to work with MSF in Guatemala. We have Mark Moisaji, the Executive Director of the Palliative Care Association of Uganda, and a lot of experience both in fragile settings and in Northern Uganda humanitarian settings, and also has been doing a lot of work on compassionate leadership. And lastly, Savita Botola, a physician with the Border Security Force in the border of Bangladesh and India, and also Secretary of the Indian Association for Palliative Care and a tutor for the Master's Programme in Cardiff. You are all very, very welcome. We're going to keep Kathryn too, so we've got 4 on our panel, and I'd love you to start just telling us on chat the sorts of things you want to chat about or that have come up from those talks that you want to comment on. So please do that. But in the interim, I just wanted to start to think about the context. I mean, Kathryn made a very good point that you had to look at the context you're operating and then apply the principles of how to offer palliative care into that setting. Matteo, can I come to you first of all? Can you just tell me something about the context that you're working on in Guatemala?
Hi, everyone. Can you hear me?
Yes.
Okay. Yeah, so it was very interesting to hear Kathryn, because in Guatemala, I was working in a project where we were tackling the chronic kidney disease patients. So my job was trying to implement palliative care for these patients. And of course, the access to hemodialysis for these patients was very challenging. They had to travel from 1 a.m. in the morning to get the dialysis. Was very centralized in the capital city. So the palliative care needs to be, the implementation needs to be, you need to focus on the resources we have. This is what Kathryn was saying, and this is what we were trying to do. And in other settings, access to hemodialysis can be closer to the patient. So this was one of the challenges. The patients sometimes they were dying traveling to the hemodialysis, or they were not able to do it.
Thanks, Matteo, and thank you for reminding us of these other conditions. And I mean, chronic kidney disease, one of the highest rising in NCDs. It's going to probably overtake many other NCDs very soon, and linking particularly to things like diabetes. And thank you for reminding us of that. And certainly in Northern Uganda, we saw huge numbers of children with acquired brain injury, usually due to infectious diseases. So absolutely, the context is really important. Savita, you're working in a very different context, and you've also been involved in disaster response. Would you like to just comment on things from this issue from your perspective?
Thank you, Moira. The things that I find difficult in implementation of these programs all over my country are that palliative care as it is unknown. And unless we make it a part of undergraduate education for all healthcare workers, it is going to be very challenging to reach everyone. And I find resistance coming from the older physicians themselves. You know, that attitude of we know everything, whether it is in oncology or whether it is in the forces. People, unless and until we acknowledge that there are more things we can learn, the older people are going to be very difficult to, change their practices. And third is the opioid access. Opioid access and this taboo of discussing death. That is there in all the communities, especially in Southeast Asia. People just don't know. If you talk to them even of something as simple as advanced care planning, they'll come up, oh, no, don't talk about dying. And unless you talk about death, how are you going to engage the communities, and how are you going to explore the cultural requirements of every person, and how are you going to plan and implement those things? So first of all is to be comfortable talking about that. Second is to acknowledge that we need to learn. And third is to include it in undergraduate education. And then, yes, from there we go on to include it in education for specialized programs for the people who are involved in disaster management, make it a part of their curriculum, talk about opioid access in those situations. And can you imagine, we here do not have access to IV opioids at the field level. Whereas if you look at military literature, they say that, I was just going through something before this started, and they say that chaplains and morphine are standard issue for field formations. But I find that missing. It's not there. And people are dying of bullet injuries, gunshot injuries, road traffic accidents without access to morphine. It's painful to watch. So it has to be all encompassing, but yes, with a special focus on disaster situations. People who are involved, like we have a National Disaster Management Authority in India. So what we are trying to do is that our association is trying to reach out to them and get it as part of their training syllabus for everybody who comes, and to approach the Indian Red Cross. So because if Indian Red Cross is supposed to be the authority for training of disaster management, and if they approve palliative care and opioid access as part of the training curriculum, it becomes so much easier. Implementing things from the top to the bottom becomes so much easier than everybody having their own individual models to follow.
Thank you, Savita, and thank you for bringing in those additional perspectives. And I think there's more. We may well come back and ask others to comment on some of the issues you've raised. Thank you so much. And I think this work you've done with the disaster management training colleges is so important, and something that I think we can learn from in other settings. Mark, I'd like to bring you in here. Mark, you, of course, are very experienced working on the ground. And one of the things that came up there was, how do we link in with existing services? So there's perhaps a new humanitarian event or a surge of refugees and displaced people, and yet there are services in country. I wonder if you can talk, as the lead of a national association, how that can work, linking with the existing services and mobilizing the communities, Mark.
Yeah, thank you so much, Dr. Moira, and thank you everyone who has been speaking since we started. The Ugandan situation is an interesting one when we talk about fragile situations, and if we talk about refugees specifically. In our country right now, we talk about 1.4 million refugees coming from all around us, and of course the borders are open. That number is what can be read if you Google search and if you look at the statistics, but I'm sure there are more, because each day we begin to see. And then we also see that, for example, the children are many. They are over 61% of the refugees that come, and that's explained. That's the reason they have to come, because the men remain, the women and the children have to leave, and then sometimes the children are more. But again, we see more children come. Now, directly to the question about existing services, by the way, like for Uganda, in the majority of cases where these porous borders and where the refugees come, there will not be many services. There will not be a service per se, but the government and the disaster preparedness ministry will be there to give the basic services. What I would like to respond quickly is that as palliative care people, we need to find a way of making sure that we integrate with the responses that are going down there. For example, when the Uganda Red Cross is going down there, palliative care is always at the tail end of what the intervention should be. And yet we know that this is crucial and this is needed. I was reading around and seeing what are most of the challenges that face refugees in our country. And like in fights at water collection points, in the refugee hosting communities. And I think like people within the community are fighting at water points just to get access to water. So how do we make sure that the palliative care approach, which is more community-based, which is more home care-based, which is more compassionate and reaching the families, is able to even be integrated in services like access to water, services like access to basic treatment, because malaria is a big problem here. How do we make sure that we are there to make sure that as we reach the communities, as we support and integrate? Then the other thing that is very key for these refugee settlements in our country is security, and then the protocol all around that has been carried around the refugee areas. You don't just enter, you don't just go in there. So how do you integrate with the structure of government and the response teams, such that as you go in, they respect you, they honor you, and they make sure that. And I like the presentations because the steps were very clear. You need to have your information well, you need to have your data well, such that you convince the political leadership so that really the people who are in pain should be reached. I think I can say.
Thanks so much, Mark, and thank you for bringing in that really important perspective. And I know there's some good examples of where palliative care programs have integrated well, and we have some of those in Uganda, but that challenge, isn't it? I wonder if we could pick up this issue of education for a moment, because Kathryn, I know that you've also been speaking with ICRC, and how do we do that? How do we, you're coming from one of the key humanitarian organizations, and how do we link in and look at some of those training programs? Any thoughts on that, Kathryn?
Yeah, sure. So, education can focus on, I'm taking the example of MSF, it's my experience, so in projects. So if we know we want to, there's a priority to implement palliative care, let's say we've got our colleagues from Bentiu in South Sudan, then we go to the field and we train the team. And we do an intensive training for the team and then ongoing training. But I think, we have to think about different styles of training so we can try to access more people. So we need to think about the e-learning trainings that people can do in their own time. We know that our colleagues working the humanitarian on the front line are busy and their workload is high. So we need to think about how we can develop education programs that fit in with their working program. So, it might be having some in-person training so that they can come away from their work environment to do palliative care. And I think this is also essential, because trying to fit it in alongside seeing the patients with a webinar here, it's good, but I think it's also important to have, different ways so that people can find the module and the way of learning that works for them. So say some in-person training away from the workplace, some e-learning modules so people can do it in their own time and fit them in. But I think there's something very rich about the live webinars too, because we have this chance for discussion, chance for sharing. And I think a key part that's worth mentioning for when we think about education, we know in palliative care, it's not just the knowledge. You can read the textbooks, but we do need to see, it's the softer skills in palliative care that are quite, we can talk about them in textbooks, we can talk about them when we teach, but actually observing, I know from my own learning when I was training in palliative care, actually seeing how people have that conversation at the bedside in a particular culture, seeing how people connect with their patients and families. That's the learning. And I think we need to remember that when we're thinking about education in palliative care, that it's really important that people can observe good palliative care. What does it look like to really connect in that moment when someone's dying? What does it look like to really be present with the family? How does that feel? What's the feeling there? And I think, as we move forward, we need to think about how we can increase the capacity to actually have this observation training, bedside training, alongside education modules that we develop.
Thank you, Kathryn. Now we've got a couple of interesting points being brought up. Amjad, in Gaza, you're talking about the fact that people don't know what they don't know, whether that's patients, healthcare providers, and that may link into this. What we've been talking about is raising awareness of what palliative care is. I wonder if anyone's got any comments, or any of our panelists, on how we might do that, because he's got a very good point. We might ask people, do you need palliative care? But if they don't know what we're talking about, they're going to find it difficult to answer that. And that applies to our humanitarian colleagues, but also patients and families. So Mark, I think you've probably done a fair bit of work of this in Uganda. How do we raise that sort of general awareness amongst community members, but also healthcare workers? Do you have any thoughts, Mark?
Yeah, I think that's a very big point, and it's something to always think about. In Uganda, we had a time when we went to the ministry, to the OPM, the Office of the Prime Minister, and we are speaking to partners who are implementing within the refugee hosting communities. And indeed, people do not know what they don't know, that's for sure. And starting from that point, remember, there are people who have, and organizations who have made it, and they are really there for those in charge in government to look at whenever there is a disaster, whenever there is a humanitarian situation to respond to. Those are the people you want to start with to make sure they understand or they appreciate the need for palliative care to be integrated within the approach of work that is going down there. And at the community level, you need to work with the locals or within the community, and people who are opinion leaders, but people who can translate and inform and influence and make it so easy for whichever program is coming within the area. And there are always those people. So the best way to make sure that you permeate the community with information, with and being able to make sure that people know what you are doing is to work with people who are on the ground and to work with those people who are leading as opinion leaders, as community leaders. Surprisingly, let's say in Uganda, for us in our setting culturally, there are always people who come up front to address issues as volunteers. They appoint themselves. And those are the people that you may need to identify as you do your needs assessment. Who is the point of contact? Who can we work with? Whom do we make sure that once we send our message is out there? So you go high level, you intervene at the government level where the interventions are starting from, but you make sure you don't lose the base. And as you correct your information, the statistics that have been generated were back in your interventions. Please don't leave those ones behind. Let the figures speak such that they contribute to making sure that they build your case and make sure that people understand you. And maybe lastly, we have had many appeals, even on radios, on TV and on newspapers, but in fragile settings, sometimes these things don't really work a lot. So you may need to use local solutions like public announcers, like moving around into those communities to speak to the public with a public announcer or something like that. So the traditional media may not really support a lot in such settings, except where it has taken some time and where the settlements have been, like in some parts of the country where refugees have been settled for some time. Thank you.
Thank you so much, Mark, and some really good points there. And Khadir from Jordan, I see that you put a comment that just about mirrors Mark, and yet Khadir, you're in Jordan. So some really common and really strong points being raised. Thank you so much. Matteo, sorry. Please comment.
Yeah, I just wanted to add that maybe one of the important things is that we should advocate for the all the university and the medical schools and nursing schools have palliative care in their plans, because this is something that for example, in Central America, in El Salvador, it has had a very good success, because now the doctors and the nurses receive this training, and it make it easier for the also, for example, the specialist. With the nephrologist, we had a lot of problems because everybody understands palliative care on their way to understand palliative care. Any one of us has different ways of understanding. So it is very important that we start from the beginning. When we start to study medicine or nursing school, we heard about palliative care, and we have this in mind.
Brilliant. Thank you. And such an important point. I think Savita started by making that point. Coming back to what Mark was saying as well, can I just add, I've seen a tremendous impact of using radio, because radio is often available when other media options are not available. And a program we were working with colleagues in Uganda literally reached hundreds of thousands when the radio was used. So finding what works in that setting, and there are specific refugee radio programs, and that brought a lot of people to family caregiver training. Maybe just changing the tack a little bit. Sarita, a question that came up yesterday, and I think has been touched on today, is the caregivers themselves, the healthcare workers, particularly those who are facing and seeing trauma and themselves are working in difficult situations. Any comments on how we support those who are working in these difficult situations, Sarita?
Now, Moira, from my experience of the last 2 years, during COVID, we have seen mass casualties happening, and people we're just not having that surge capacity in the hospitals when it came. But in spite of all that, we were not able to have counselors everywhere, but online counseling for healthcare workers, I have seen it working. Grief support and support for stress, even online, has been, just doing some reflective exercises, sitting in a group, breathing together, and talking about it to people you can trust in a closed, confined, just like a group we are sitting in. People sharing their experiences online, that has helped. And that is a huge thing that can happen, because in communities like ours, we do not have trained counselors everywhere, and we cannot have them during disasters. Plus, we do train our people during palliative care for self-care. So having your own skills built up and having a closed network where you can share things confidentially. Because a lot of disaster situations require confidentiality for workers, for their safety. So a closed confidential group where you can just sit, meditate, talk, debrief together.
Mm-hmm.
You're not always allowed to openly discuss things, what all went wrong. Government policies come in, your own organizational policies come in, and so many times you're not able to discuss what could have been better, what went wrong. So having a confidential group where all of these things can be discussed to prepare you for what can be done better next time, reflection, and probably just a support group online would work wonders.
Thank you, Savita. Thank you. And I know you and I were part of a COVID online training program, and I was really quite struck by how many people chose an educational event to share at quite a deep level, and that sense of joining with each other in the struggle was really important. Yeah. Kathryn, I don't know if you have anything you want to comment on that issue.
Yeah, I think it's critically important, isn't it? Because often the staff that would be providing the care are already overwhelmed. They're facing high mortality, they're facing work stress, and just having a space where you can say, this is hard, this is hard, and we're sharing this together, and this is really difficult. And some sort of, one has to take care of oneself to be able to care for another. And we know that so much in palliative care, and it can easily be forgotten in the field when things are busy. People just keep going. You see so much overwork and burnout. And actually, we need to, part of the education has to be care for yourself so you can deliver this compassionate care to others, because without that step, it's going to be very difficult to provide the care that's needed.
Thanks, Kathryn. I want to just listen, a few more minutes left, pick up an issue that Bang brought up, and that was in inpatient and outpatient care. And I did hear comments also in the work we were doing in northern Uganda that people are being rejected at home, they're not being cared for at home, they're being neglected. But I also heard that the community was fractured and they're struggling, they're a bit frightened, and they also want to see that they're doing everything for their patient. And trust has broken down between healthcare and community, and that can add to that difficulty of planning for care at home. Mark, maybe I'll bring you back in here again. How do you think we tackle this issue of communities that have actually essentially been fractured and then finding it quite hard to do care at home, and that can look like they're neglecting their colleagues and make it hard to do home-based care? Any thoughts, Mark?
Yeah, thank you so much. And I wanted to give a comment on making sure that the carer is cared for, and then I come to your question.
Sure.
Now, we can't give what we don't have. That's always a big point to always remember. If we are moving out to say we are compassionate, we want to show love to people, and we want to hear them speak to us, then we must be filled, make sure that we have enough to give out. At the point when we are not well resourced, and so we need to step back always and rejuvenate ourselves and be sure we have what we think we want to give out. Now, on the matter of home care and community approaches to palliative care, of course, Moira, you very well, you are familiar with the Ugandan context. In some settings, this is not working well, and in the fragile situations, then it becomes worse. When we have, for example, disasters and the waters sweep around the hill, and then the families have to move. You're not even talking about a home. In that case, people are gathered in one place, and you can't talk about how they are facing. But like I had said before, we need to find a way of making sure that the government and the bigger entities we are always responding to these issues are always in touch, and not just in touch when there is a disaster or when the refugees are more, but they are always invited to our meetings. They are always in the know of what we are doing, that we are always sharing our reports as palliative care people with these agencies, such that at any point in time, they don't forget or they don't take us lightly. They always know that the intervention is important. That is key. And now, every community, like I had said, has some way of coping mechanisms. Even in the very worst scenario of a refugee setting, that's the influx In Uganda, we've seen this many, many times. There is always that coping mechanism that we want to rely on and to make sure that we are not bringing in something from far to bombard it on the people. When you talk about the North, for example, there is a lady called Vicky Opia who works in Germany, who has been part of the community. Her response has always been that you reach out to the community in need, according to the needs they have put forward and according to what really matters to them at that point in time. That is the way you are going to make sure that you intervene. And we will not do everything. We will not be able to see everyone, but each of the health facility that is overwhelmed, that is within a setting where a disaster or a humanitarian setting is, let's try to work with them to see how much they can do. If we cannot go to the home at that particular point in time, what can we make sure we do to make sure that the service still reaches somebody who is in a home? I've seen in refugee settings in Nachivale, way back near Rwanda, where the homes have been caged, that the settlements, they fear because they have come a long way from Somalia with all this kind of stigma and everything. They even tag themselves and they don't want somebody to penetrate and get there. But working within their opinion leaders, sometimes with the people who inform and who come to inform the hospice program that there is somebody in that home, it helps. And this person goes there. And our chaplaincy, our psychosocial support, our community volunteers, we are not yet there, but we need to strengthen those areas. I've given us such a long answer, but I hope I've tried to answer.
No, thank you. And I think that's a lovely place, I think, to draw our webinar to a close, although there's more to talk about. I've actually shared something on the chat that was that I was introduced to with my Gaza friends. If you're on from Gaza and you're part of the diploma program, could you just put your video on for a minute and wave to us so we can all see you? Because you're an example of integrated education. This is a diploma program running in Gaza. PallCHASE is one of the partners in that. And just like Amjad was sharing, we need to let people on the ground have the knowledge and the skills to actually implement this. But we were discussing self-care and we were discussing what it meant to have compassion and to be a human being. And this was the song that was shared with me by my dear friend, Dr. Khamis Alessi, who's on this call as well, and talking what it means to be human. And I would encourage you to click on that and listen to it. It's very, very encouraging. It's an Egyptian singer who I think is very famous, but also just talks about being human. And what a lovely place to end this webinar. We're here because we care about humanity, we care about each other, and we care about making a difference in our world. And thank you for all of being part of that. Thank you very much to Kathryn and to Megan for their really helpful input. Thank you to Matteo, for Mark, and for Savita, who had to leave. Your input was really, really helpful. To everybody who posted in the chat and joined in the discussion. We even have someone I know that joined at 4 a.m. From a first ever meeting here, a surgeon interested in palliative care, who's joining us today for the first time. So it's really great to see this network growing. Erin, thank you for managing this webinar and for helping with our comms. And I know that the comms is really improving. We've got more to go, but we're trying to improve to network more effectively. So please join a working group. I think there might be a link put in the chat in a moment, and also a link about evaluation of this webinar. Share with your groups, encourage others to join. We're particularly short of those who work primarily in a humanitarian sector. So Matteo and Kathryn, thank you for representing that area particularly today, but do bring in others. And if there's things you think about we should be looking at, do that. But let us all remember that we are human and we have the privilege of reaching out to one another. But I love Mark's comment. What's that? We can't eat what we don't have. So let's care for ourselves and show compassion to ourselves as well as to one another. So I think please click on those and give some feedback. First of all, Megan stays as part of our panel, and then we add to that panel Dr. Zippy Ali and Dr. Ednan Hamza. Now, Zippy and Ednan, would you like to introduce yourselves? Ednan, I know of you that you're CEO of Hospice Malaysia, chair of the Asia Pacific Hospice Network, a palliative care clinician, but maybe you want to say something else, and you're joining us from East Timor.
Thanks. Yes, that's correct. My current sort of work is both in Malaysia and in the region as APHN chair. I'm currently involved in capacity building programs around Asia, in the Asia Pacific. And in the last few weeks, I've been in Laos, Philippines, Sarawak, and this week I'm in East Timor. We've just actually signed an MOU with the Ministry of Health for a three-year training program in East Timor. So it's exciting. Thank you very much.
Welcome. Thank you very much. And Zippy, I think many people will know Zippy. Helped found Nairobi Hospice, was the lead for palliative care in Kenya, the KEPCA Association, for many years, I think 17 years, Zippy. And now you're leading the NCD Alliance in Kenya. Please tell us a bit, and you're doing a lot of international advocacy. Zippy, just say a few words to us.
So thank you very much, Moira. I'm happy to be here this afternoon or evening. Yes, I'm a palliative care practitioner, physician, but retired about 1.5 years ago. I've had experience working with patients for over 15 years at the hospice and another 15 years in advocacy, training, and policy. So right now I chair the NCD Alliance. It's a voluntary position as the board chair. And also I sit on the board of the African Palliative Care Association, which I joined just last year. Yes, thank you.
Thank you very much. So we're here to just respond and think a bit more about the issues that were raised. Really good presentations, grounded in practical application, which is brilliant. Megan, did you want to say something before we start?
Yeah, I think we do have one more panelist, Mateo Cerro from
so
Guatemala.
Mateo is a panelist tomorrow and he wants to observe today.
Okay, sorry.
So yeah, he says he's traveling today. We'll look forward to his input tomorrow, but that's lovely. Grant, I think I wanted to start, just get the ball rolling, because Edna and Zippy in particular, you're very experienced in Asia and in Africa and in other places. What do you feel are the differences, if any, between the humanitarian picture described and the low income and maybe even fragile settings that you work in? Maybe you don't feel this differences, maybe you do. Just a comment on that. Edna, what do you think?
I actually think, I mean, listening to those two brilliant presentations, I find incredible similarities between sort of fragile, low-income situations and the humanitarian crisis. I think the difference is the sheer intensity, the impact of a humanitarian disaster as opposed to a situation that's already been there over a period of time. So I think that creates a greater sort of impact and necessity, urgency for more immediate intervention. Whereas what I'm sensing is that this has been going on for a while, and there is perhaps a little bit more time that we can take in order to effect change.
Okay, and Zippy, the same question, but maybe also comment on, you know, I think it was Kathryn made the point that we need to link in with what's happening there already and how important that is. And just any thoughts or comments on these two issues, Zippy?
Yes, and thank you to Kathryn and Megan. Those were really great presentations. I think anybody who has listened to this session will probably be able to start palliative care wherever they are. It doesn't have to be only the humanitarian situations. Yeah, I think I also agree with Dr. Eden. I think what really comes out is that as much as the situations are very similar for low-income countries, the challenges we have are the same: healthcare workers, funding, weak healthcare systems. I think it's more intense for people who are in humanitarian situations because first, there's no particular funding for palliative care in those places, and secondly, because most of the healthcare workers working, for example, in our refugee camps in Kenya, you go and train, and then 5-6 months later, the whole team that you trained leaves. So there is no sustainability in terms of services being able to continue, and of course, even the priority. These people find themselves not being a priority in whichever country they are in. They're not citizens, so they're not even under the health insurance of that country and cannot access treatment, for example, for cancer because it's not in the budget, it's not in the systems. So I think the challenges might be same, but I think the challenges are more intense when you're living in a country that is not your own country, when you're a refugee, when you have almost no rights to health or to whatever. I think you asked something about linkage, and I like the presentation today talked about the fact that before we go and set up these services, we need to engage the people in those regions. We always think we know the best, and we don't engage the people themselves because we don't know exactly what their gaps are and how they're supposed to be able to address those gaps. So whatever is existing, for example, and again, taking our own country as an example, We have done some training in some of the two major, in fact, maybe the wildest refugee camps. But if you don't go and fit within what is existing there and you try to bring something new, there will be resistance. So we need to find out what are the existing resources that are there that we can link on and work with. And we talked about community healthcare workers as well in the presentations. These are very key. We need to be able to work with community health workers, recognizing and remembering community health workers themselves could also be victims of what we're addressing, and that also they're not motivated, they're not compensated, so that it's very difficult sometimes for them to keep up giving these sessions. So we also need to address how can we motivate them, how can we educate them, how can we work with them to be able to reach into the community, because they're the ones who are the nearest to the patients. So I think there are many things that have been addressed today that are very important for us and I know in Kenya we've been doing a training, Erin, training people so that we can have people trained in how to work in these conditions. And I'm hoping that the lessons learned today in these two presentations will actually help our healthcare workers who are working in these situations to be able to set up and facilitate and fast track palliative care services to those who are in need. Thank you.
Thank you, Zippy. Thank you. And bringing in your experience in there. And interestingly, in Northern Uganda, we actually find that our refugees access to cancer care better because they have streams for referral, but the host populations living right next door don't have. So it's very interesting, isn't it? And we're collecting some research data from there. I see a question about home-based care workers, and you made that point very strongly. And again, that's the vehicle in the north. Now, Megan, I think you talked about training packages. We have a question about how we can, get training packages or ways in which we can train home-based care workers coming from the audience, from the participants. Any comments, Megan?
Yeah, that's a great question. And I think because they are really the cornerstone, like they are the ones who are day in, day out seeing a lot of patients and just like, capturing a lot of the volume of the care needs, they do need training. So we have a training package that we developed in Bangladesh. And I think there are several others, so we maybe can just share them on our website. It's a pretty general package. Like it's similar to what you use if you have like volunteer training package, can be a similar one, even for family carers. Like you shouldn't, I don't find you can train them together, but you can use a very similar type of training because they aren't having like a really strong like health and education background. So, but yeah, we do pay them. I know somebody mentioned like if they're unpaid. So we actually pay them, and like in refugee camps, I don't know about in the whole world, but in a lot of places, like the WHO sets a standard or the UN sets a standard for what you can pay them because they don't want the salaries going kind of up and up and up. There's pros and cons to that, but there is a set amount you're allowed to pay them. And so we usually pay them whatever's the maximum on that set amount. It's usually quite low, unfortunately, but it does motivate them and sustain them. And our experience was like, because they had limited other opportunities, they were highly interested and motivated to take this as an opportunity. Like we got a lot of like young men, like around 20 to 25, which, typically that's a group that's out and working, but in this camp, there wasn't a lot of work opportunities for that group of people. And so they were very interested to do this and to have interaction with like physicians and nurses and like be really involved in. They felt very motivated to help their own community. They like really derived a lot of meaning out of that. And also just like to do something every day that was like valuable. So obviously that's not going to apply everywhere, but that was a huge experience that we were not expecting and we found.
No, and I think that's really, really important actually, is not to see, I think the HIV campaigns taught us nothing for us without us, nothing to us without us. And I think that's such an important, and I hear that a lot from people in humanitarian settings. Just so that everybody's aware, this is a difficult term because it encompasses acute events, and Edna, you talked about that more intense acute event, but also people live in refugee settings for up to 20 years on average. So those more protracted settings, it includes things like floods and earthquakes and droughts. It also includes conflict and chronic conflict. And perhaps there's another term which I certainly use in my work, which is fragile settings, which is a globally recognized term for areas that are either in or close to areas of political or environmental instability. And the environmental component is pretty huge. So it's a tricky one, isn't it? I see some questions too around access to medicines. Now, this is a huge one. Vicky, thank you for sharing the link. I love that link from IHPC. I just wish there was something about not just pandemics, other humanitarian settings. That would be my little request back to IHPC. But what about our panelists? Anything we can say? A lot of people are saying in the chat, and Megan, you showed in your needs assessment, access to opioids is a huge issue. Zippy, I know you've been at many of these global advocacy meetings. Any tips or suggestions of what we can do to address some of these opioid access crises?
First, I think we have to start with advocacy and awareness. If we don't educate our healthcare systems, our policymakers, and particularly our healthcare workers on opioids, the safe use of opioids, then we will not really get anywhere. In Kenya, one of the things we've done is worked with an organization that deals with drug and alcohol abuse, which actually regulates also use of opioids, to change the language in the amendment that we have on psychotic and narcotropic drugs, to remove things like poison, penalties for doctors, prison, but to put language that is useful. And so that has really helped a lot. But I think one of the things that helped also change the way people, doctors, particularly doctors and nurses and others, view how the use of opioids was to go into hospitals and train them on how to use opioids and how to use them safely, and demystify all those things that opioids will become addicted and the opioids will kill you. And I think that they have seen that it actually works if you are trained, putting it into the curriculum, the medical nursing curriculum, the undergraduate medical curriculum. All those things are very important. It's advocacy, it's training, and of course, it's also trying to help the system understand how they can, for Kenya, we are now also manufacturing our own opioids of oral morphine. We didn't do that before. We would have everybody doing their own things, but now the government has realized that opioids are very important and have put opioids in the essential medicine list. Of course, these are available in the public, mission, and private hospitals, but availability in those humanitarian institutions is still a challenge because they don't belong to the government system. They would have to kind of make of a special request for those medicines to be, but they can buy them. So it's actually going there and educating the people there that they can actually use these medicines for pain management safely. So I think a lot is on education, creating awareness, and navigating people where they can actually access these medicines for the patients who need them. And of course, also, of course, the beneficiaries need to be educated as well, because you find people don't want to use, they think I'll be addicted, I will die, because of what they read on internet and Dr. Google and everything. So again, even the beneficiaries need to be educated as well.
Thank you, Zippy. For those of you asking for guidelines and so on, I see, Erin, thank you for sharing them. This is also something as a network we hope you will find in our newsletters, in our websites, in our resources. We're really trying to find that the PallCHASE website is a place where you can go and find some of the information you're asking about. I'm going to just borrow a couple of minutes into our AGM because there's one more issue that has come up, and all the issues are really important for sure. One just follow up from Zippy's comment. There was a change at WHO level to make sure that the emergency boxes could contain opiates, but it's still a could. So some people don't order them because they think if there's an opiate in it, it might slow down access and they want all the rest of the medicine. So there's a lot of work to be done for sure, and a lot of advocacy. In Uganda, they link them in with existing services like you do in Kenya and get the opiates that way. Now, Rick and others talked about trauma-informed care, talk about the impact on the caregivers. Would any of you, I mean, maybe ask Megan, because I know you've been intimately involved, what do we do about supporting caregivers in these situations, particularly thinking about healthcare givers?
Yeah, I think that's really important, and we always build that into our programming, even into our needs assessment. We actually built in self-care or caregivers, interviewer support, because you take a young group of individuals who are going out and doing those interviews, and we were like quite worried that they would hear a lot of stories of suffering. They interviewed a lot of very sick patients who were not getting any support really. So we actually had debriefing with them. We discussed this with them. We made sure they were connected to resources. And we really, as the sort of the leads, myself and Dr. Rosanna, provided that support to them and helped them sort of go through those experiences. So I think that is important, and we were conscious of that from the beginning. Interestingly, again, it was actually a positive experience for them. They said that they felt they could do something. They were empowered. They actually felt like going and seeing these people and talking to them was therapeutic for the patients. So it was kind of different than what we would expect, but we were careful, and all of our training, we do include training on like sort of a trauma-informed approach and self-care and spiritual care.
Yeah, thank you. I know we've looked at this. I know I can see Olena on the call with the initiatives, for example, forming networks. Joan, you've mentioned that, cross-border networks that have been done with colleagues in Ukraine in the current crisis. But Megan, I would agree, some of the people that we've worked with, including the families, very movingly saying that, one of them said to me, I want to apologize to my father, because if I'd known what I know now, I could have cared for him better. So that sense of being together, making a difference and working with people, and another young man who talks about how his community want to care for their own, but they just have been fractured. They need support to do that. Mm-hmm. We could go on for a long time, and the next webinar will be slightly longer, so there'll be more chance to chat. But I'm just going to ask each of our panelists just to give us some final comments as we come to the end of this session. So can I start with Zippy?
Okay, I just want to say that I think everything is possible. There's nothing that's impossible. I think once you have set your mind on it, you find the systems to help you, that you can make it work. So I don't think we should give up on any situation. We should continue advocating, educating, training, and ensuring that people have a better quality of life. And the motto that I saw in one of the links you sent is actually similar to the Nairobi Hospice motto, putting life into their days. That should be our motto. Any day that somebody's alive, breathing, should be a meaningful day for them. Thank you.
Thank you, Zippy, and for reminding us. We use that phrase everywhere, but did you know that came from Kenya? Yeah. It's about the quality of care, yeah, putting not just days into their life, but life into their days. Wonderful. Ednan?
I think one of the things I found very helpful was commitment over a long period of time. We used to go intervene in a country over short periods, a week, a month. And now we're finding that is not sustainable. And what we're now doing is 3-year engagement programs where we work with the same people, we make friends with government, policymakers, NGOs, volunteers, and we really build up a long-term relationship with them quietly, working together in capacity building. And I think that it has a much larger footprint and a much more sustainable.
Thank you, Ednan. So yes, although the disaster may happen in a short space of time, the impact goes on for a long time, fragile settings. So forming those longer term relationships and input. Thank you very much for that wisdom. Megan?
I think my final words would be just engage the community and make it a shared solution, because there's so much strength there. You'll otherwise you feel overwhelmed by just the need, and what are you going to do to make anything better? And it's been so rewarding and sustaining and really empowering for us to work with the community and see how much strength and resilience and compassion is there.
Thank you so much. Thank you. We will finish the discussion there. If you would like more discussion, come back tomorrow. We'll hear the same talks, but then we won't have Zippy and Ednan, unfortunately, but we will have Mateo from South America, from Guatemala. We'll been working in Guatemala. We will have Mark Mwesaji from Uganda, and we will have, somebody help me out, we will have Savita Botola, how could I forget Savita, who works for the Border Security Force in India. So we'll pick up these issues and discuss them further, and feel free to join us in that. We'll have a bit more time. However, we are delighted to invite you to stay for our AGM. It's going to be focused on what PallCHASE is, and then what the work they've been doing. And we will be answering some of the points you've raised, because we'll be talking about some of the working groups, what's been achieved, and what more could be done. And you might well find places where you could get involved and add your enthusiasm. And thank you so much, everyone, for joining today.